I first met Dr. Almaguel at a symposium several years back where we were both speaking. His subject was discussing molecular imaging. I was so impressed with the information he presented that I invited him to speak to our membership. As a result of his very informative presentation on molecular imaging, we asked him to return to the forum. Tonight, we have a special treat for the audience. After the conclusion of Dr. Almaguel's presentation, he has invited a patient to speak on his experience being treated by Dr. Almaguel. Immediately after, we opened it up for questions from the audience. Immediately after the patient has spoken, we'll open it up for the audience. Dr. Almaguel focuses on personalized intervention and using innovative biomarker tools to understand the underlying mechanisms of the disease. And this speaks directly to precision medicine. His dedication to improve patients' outcomes centers using multi-modality molecular imaging for the detection of potential therapeutic targets resulted in early intervention and enhanced non-invasive personalized therapies. Dr. Almaguel is an assistant professor of radiology and basic science at Loma Linda University and the director of molecular imaging and therapeutic program at Loma Linda University Cancer Center. He is board certified in nuclear medicine. During 2017 and 18, he was director of Loma Linda Molecular Imaging and Precision Health Institute. Dr. Almaguel graduated from the Medical Science Training Program, Loma Linda University School of Medicine, 2010. He received the School of Medicine's Dean Award for Academic and Research Excellence. Let's give Dr. Almaguel a very warm welcome. Dr. Almaguel.
Thank you for the invitation. I am honored to be around such select group, and I can tell you that is for me is just a treat to have the opportunity of get new friends every day. Let's put it that way. That's how I describe my career here. I mean, I get new people every day. I get new friends, and you're gonna see something around that today. So I wanted to tell you about the future of prostate cancer care. I mean, I truly believe that we are on the edge of something that's gonna change the world for prostate cancer and for many other cancers. And the way this works is complicated, right? We have a problem, cancer is a problem, and we need to deal with this, right? Soon, prostate cancer by itself is gonna be the #1 cause of death in America. So we need to have an idea how that's gonna go. So everybody here in this forum knows about what happens when you get diagnosed with prostate cancer. And there's some specific things that we do. And I am telling you that these are good things, but I believe that we need to add something in order to get better at diagnosing and get better at therapeutics. And what I am actively saying is that our guidelines are about to change. And we will help more people because we're going to be able to detect and treat prostate cancer earlier. As you know, a lot of you have had the opportunity of or the calling of being here today, and you understand when I'm calling an interdisciplinary journey. We have multiple disciplines leading your care. And I think we need to understand that we have done a lot in the last half a century.
What do you mean, where are my glasses? Let me turn the TV down.
So there are physicians that have given their life for this, and I can tell you that that Dr. Huggins changed the world. He found out how to starve prostate cancer and made results. We have hormone therapy for many patients, and it's a foundation of many things that have been done. In the future, after Dr. Huggins, we have amazing technology in surgery, right? We have the Da Vinci instrument where the incisions are smaller and the outcomes are better. In radiation, we have proton, it's even more, precise than conventional radiation. We have done great advances, but let me tell you this, there is a lot to be done. We have around 30% of men that will the disease is gonna recur, and I think we need to do something a little bit better, because 30% of 3 million patients, there are a lot of patients, and this is today a reality. There is a lot of people that that are gonna have problems with prostate cancer, so we need to get together and figure out a better way. And I don't want to emphasize too many things here, but sometimes doing something better means changes, right? We need to do something different in order to expect a different result. And I believe that molecular imaging is going to be playing a key role here. And how do I describe molecular imaging? Molecular imaging is like our way of detecting that wolf that is dressing like a sheep, okay? How do we detect cancer for normal cells, for normal tissue? And this is how we are doing this. Molecular imaging is allowing us to see this cancer here that we couldn't see in the structural imaging before. So take away this as putting the glasses of technology, and look, it all started with a biomarker. So we now understand that there is a biomarker that is overexpressed up to 1,000 times in prostate cancer versus low-grade prostate cancer or no prostate cancer. And now we can use that because we know that if you have high expression of this biomarker, of this protein, you have high expression, you have bad survival, and you have low expression, you have pretty good survival. So now we know that this is a problem, and we have used this to leverage the next step. So in the past, we did bone scans, and they were great. That's what the only thing we had. So if I tell you that this patient had a lot more disease than you can see, you might not believe me, because it's basically not, we cannot see it here. The same thing, I can tell you that there is a wolf here, and you say, come on, I cannot see it. But I can tell you, if you put the right image technology on, the right scope, you can see it. The same thing with the new technology, with the newest next generation image. This is the same patient, the same week. So there was a lot of diseases there that we were not seeing, and we were not doing a favor to this patient by telling him that, oh, we don't see anything, you might be okay. So molecular imaging is changing the way we treat patients. So we're talking about up to 62% in management change by you doing this amazing imaging. And this is key if we want to get to the next level. And the next level is no more trial and error. The next level is precise. Okay, if this therapy can help you, we'll do it. If it cannot help you, we just stop. So we have to understand that we're not the same, and we need to have personalized interventions. By using molecular imaging, we can start the treatment a lot earlier, and this is going to change the way we treat this disease. In the past, we blindly will give treatments to where we think the cancer is, or we'll let you wait to see if we could see the cancer in the future. This will not happen again. We will have more precise interventions. We will not be doing these things. And let me tell you how this works. You have, again, multiple physicians, great people that are trying to do the best for the patients, but we need together to join heads and join efforts for the best of patients. Let me give you a couple of experience with patients that I have treated personally through the route of radiation therapy. So it's a 58-year-old patient of mine. I mean, extremely active, pretty young. So PSA started rising. We performed this molecular imaging technique, PSMA scan, and we saw the cancer right there. You couldn't see in the structural images, but the cancer was there. PSA was 16. He was just diagnosed the first month he got to me. So it's not fair that he got this access so early. But look, he got, oh, I went the other way. So this is what happened. How many times? I mean, 6-7 months after the therapy, his disease was residing, going down, and his PSA become almost undetectable. So this is what we can do when we are precise, and we know this from trials from many groups, that when you're able to pinpoint the cancer with radiation, you can see a big difference. And I don't want to get into too much details, but I can tell you in surgery, it's no difference, okay? Giving a surgeon a target will help you, right? The surgeons are amazing at what they do, but if they have the wrong target, or if they do the right surgery, I mean, the best surgery in the wrong patient, it's not gonna be helping you, right? If you have if you can give him a target, you have localized disease, then surgeons are amazing. They'll take out the disease, and then it'll be up to you to choose what you want to do. But I can tell you, surgeons that did amazing surgeries in patients that were not the right ones, they suffer. I mean, I have seen this directly. Patients after surgery, PSA doubling. There was disease outside the prostate, and they got the surgery when they might not have that might not have been the best step for them. So let's talk about beyond imaging. We have patients that get to me with disease, widespread disease. What do we do with these patients? And I can tell you that we have a role to play here. And this is, I have only talked about the half of theranostics, right? Just the imaging. Just we do the imaging, the diagnostics, and then we plan the best therapy. And how basically it works like this. It's just with the same molecule, we can take a picture, or we can send a micronuclear bomb to destroy that cell. It's as simple as that. A very complicated concept made it simple. So it's radioisotopes that are completely different. Radioisotopes that just like a camera, and other ones that are just bombs. And if we can target the therapy to those wolves, then we'll have good outcomes, and there'll be little to none side effects. So I can tell you that I have seen this before. Patients with disease everywhere, high PSAs, and after 4 therapies, I mean less than a year, we have these results. And how does it work? Is because we are so specific at detecting the cancer and detecting it in a way that we can send the medication to the right place. And if we see what we treat and we treat what we see, we believe this is going to be better. And the best thing about theranostics is not only that you can pinpoint where the therapy is going to go, you can actually see and determine where is the therapy going. And you can, this is an image of the therapeutic, after the lutetium injection, you can see that the therapy is going to those metastases. And you can predict what happens to these patients if you see where the therapy is going. And I can tell you that we're still working on this. We're still trying to figure out when do we treat, and when in the disease evolution we use this technology. In this specific study, it was done as before chemotherapy, because these patients couldn't afford the $60,000 that enzalutamide and Zytiga will cost this patient in Africa. So I can tell you, we are still working on this, and we're gonna have a lot more to say in the future. I'm gonna tell you there are patients in this forum right now that has had this response, from disease everywhere to basically complete remission, and it's been like this for a couple of years. And this patient is not only feeling better, it's not only the pictures are not better, but he's feeling better. He was keen here, and he'll tell you about that later. But also, these are specific words from him. No, he didn't have any side effects, and of course, he kind of got there a little earlier than many patients because of the lack of knowledge that was in that time a couple of years ago. But the results are concurrent. We have lower side effects than with other therapies, and is really a matter of how specific you are in your therapy, and how conventional therapies are, because they're not specific, you have to burn that forest, when with this new precision oncology techniques, you can just select the problem and target it. So it's not me saying this. The clinical the vision trial and the therapy trial are saying that these therapies are not only better for the patient, but actually increasing the quality of life. And I wanted to keep this short because I want to give you the opportunity of talk to somebody that had gone through this. But I will warn you that in the future we will be moving these interventions earlier in the disease evolution of prostate cancer, and this might be something that will help us to put the word C, the cure word, into prostate cancer. Because I personally believe that if you do this, if you're more precise, you're gonna have a chance of cure. If you start early, if you do the right therapy, the precise therapy early, and this is not me, this is the community is moving in that direction. I can tell you this is just the tip of the iceberg. I'm working now with new tracers to target basically all solid tumors, adenocarcinomas. I'm working specifically in glioblastoma, breast cancer. I mean, we are gonna do something amazing for cancer care as a whole. And I have to warn you that there is a lot of fear of change, and that's why today I want to make a short presentation and ask and show you that people that have gone through this, that have had good results, are doing this, are having these results because they were treated when their immune system could help, when they were still strong. And I can tell you that gives me hope. And before we open up for questions, and I know maybe we can even open for questions right now, I would like Alan to share about his story. And let me ask you, Alan, something. You know, tell me about your journey with prostate cancer. I had the privilege of having Alan as one of my patients, and he had gratefully agreed to be here today. Is just a treat to have people that have the heart to share with others and to help others. Alan has taken hundreds of calls on my behalf after that article that came off in the Orange County Registry, and just trying to help prostate cancer patients together. Alan, can you introduce yourself? You're muted, Alan.
Myself. Okay, there we go. Well, it's nice to meet all of you and be able to see you and visit. My experience with prostate cancer, you know, when it hits you in the face and all of a sudden you have physical problems and you can't put your finger on it, and even some of the doctors were telling me it had nothing to do with my prostate, some of my issues. I'm in construction sales, and I could figure out, hey, the part is next to the other part that's going to complicate. So anyway, I researched what I could do. Of course, I got started on hormone therapy. I was in Kaiser and started with hormone therapy and researched what I should do. And of course, being a believer, I said, open the right doors, close the wrong doors. And so I did the research and found out a little bit more about theranostics, that it was in the making, and found out that Germany was there, and was able to go there. And lo and behold, I'm standing there, and Frankie walks up to me and he said, "Are you Alan from California?" "I'm Frankie from Loma Linda, California." And so it was nice to meet him. And I said, "My wife's born in Loma Linda, so we'll come down and see your kids and have lunch." Anyway, my journey was get over there, sit down, take an x-ray when I arrived, treatment the next day, 48 hours in the clinic, just sit there, and no side effects at all. And I think nutrition is huge. When you go into this, you have to be putting good food in. But 3 treatments, 3 months apart. And Dr. Kilcarney over there, a wonderful person, doctor, just a good experience. And I'm being in sales, I'm around a lot of middle-aged people, I call us. We're middle-aged, we're not old. I meet a lot of them that have had cancer issues and they've had the wrong treatment. So I've seen a lot of suffering that was unnecessary. And, you know, my heart goes out to those people that have had to go through it and had the wrong treatment. Maybe surgery, and then it spread. And, you know, you've heard all this before, but I had nothing but success. And I believe Frankie is on it, you know, where he's saying, hey, this is up and coming, and it's going to be able to help people on the front end of it, and not wait till it's so bad that, you know, you're in tough shape or you have pain or before you get there. But
and I can tell you that is coming. We're going to have it in the US soon. And you already have the PSMA imaging available everywhere, basically. If you have questions about imaging, let me know. I'll be glad to help you with an order and get your image. I think it's going to help you, your journey. Doesn't matter what you choose, if it's surgery, radiation, whatever it is, you want to know this, the baseline of your disease. And like I said, you know, I believe the horizon for prostate cancer is changing. There'll be a lot less guessing and a lot more precision in the way this disease is treated. And you're gonna see that in increased quality of life and in outcomes, better outcomes. So if you have any questions, look, I want to make this very informal. Ask questions. I don't have all the answers, but I will find out for you if I don't know. And you can ask Alan. I mean, you can ask others that have been working with me. My philosophy of life is working with friends, and when you do that, is tougher as a doctor, because now you have to respond to a friend, you know, and you need to answer their questions at odd hours. But I can tell you this: it's worth it. It is so worth it. So, question, don't be shy. You can ask Alan. You can ask me. I have no investment of any therapist. I can tell you, I would like you to get the best treatment that is for you. I mean, what I believe is that with more precise imaging, you can have better outcomes.
So this is Larry. Thank you, doctor. What I'd like to do at this point is, if you have questions, write it out on the chat tool, okay, that's on the screen, okay? If there's anybody that needs help, just let us know and we'll show you how to get there, but write it out. So while we're getting some written questions, is there anybody that would like to ask a question verbally?
Larry?
Yeah.
Yes, I would like to ask a question.
Go ahead, please.
Okay. Dr. Frankis, Dr. Metzger here. I'm the medical advisor for the group and a surgeon, so I hope you're sitting down.
Oh yeah, I like surgeons, man. I like them.
Now, let me tell you, I couldn't agree with you more. Can you believe that? After 41 years of lopping out prostates, you guys are much further ahead than we ever were. Let me ask you a question though. Which of the newer medicines that are being attached to the PSMA do you think is going to hold the most promise? I saw a report today that they put a PARP inhibitor and where is this going to go?
I mean, this field is exploding in terms of based on our ability of targeting the therapy. Look, before I used to say, man, chemotherapy is not targeted. I'm sorry if there's an oncologist here. I mean, your hair falls off and your blood counts go to the floor. I mean, because it's not targeted. But now we can target PSMA with PARP inhibitors, with docetaxel, carboxytaxel. So we're gonna have more and more precise therapy, and that's the whole point, right? I mean, and as a surgeon, first time I sat down with my chairman of surgery, right? Chairman of urology, and I was a fellow, right? And I said, look, please, I would like to help you with this imaging. I mean, I know that you want to do the best for your patients.
Yeah.
If you have a target, you can do a lot better. And the guy was, you see, that's why, I mean, surgeons, for me, man, they work really hard. I don't know if you know, the surgeons work extremely hard. I did my surgical internship. So I still get my colleagues, Frankie, why didn't you go into surgery? And I decided to come into this field because I want to be a helper for surgeons and other physicians. Basically, if you're able to have a target, you will not regret helping these patients. If you don't know what the extent of the disease is, then even if you want, you might still not choose the best for these patients. And that's the whole point. Information will make you free, and the information of where is your disease at and what is the extent of your disease is going to help you if you're a surgeon, if you're an oncologist, if you're a radiation oncologist, and it's going to help the patients.
Yes, I finally sold my stock in Depends. Thank you. Great talk.
Hey, my pleasure. I really would like to contribute and help here, because this is what the work you guys are doing is amazing. You need more knowledge, and you need more people to understand that together we can do better.
Is Frank Rogers still out at Loma Linda? Dr. Rogers?
He was there. I think he's retiring now, but he's a great guy.
We went to school together.
Oh, he's a nice guy, very nice guy. He was a
big guy.
Yeah, he was actually the director of my surgical clerkship when I was doing rotations.
Really? Oh my gosh. Well, thank you, sir.
My pleasure.
So let me go to the next question. Before I do that, though, I want to make a comment. Okay, and it's I think a critical distinction with this technology. This technology, when the PSMA attaches to the cell, okay, it distinguishes the cancer from the non-cancer cell. So it's very precise, okay? Now you correct me if I'm wrong, doctor, is that correct?
Yes, that's the inherent advantage of this. It's just that we have a biomarker that is telling us, is confirming cancer, no cancer, wolf or sheep, very clearly and reliable. So we are able to repeat this and to follow that, use it for understanding how the therapy went and use it to plan the therapy.
Thank you, doctor. Next question. This is from Bob. When will Medicare pay for the PSMA PET scan?
Very good question, Bob. I can tell you right now it's paying for it. I mean, just in the last couple of weeks. I mean, I believe that some people in this forum got a call today from an imaging center that I'm working with that it's gonna bill Medicare and you don't have to pay. I mean, hopefully they don't charge you too much of a copay. But I had a patient last week that paid $0, right? So this is happening right now.
Thank you.
Alan, do you agree with that?
0. She just called me and said, you can show up, you won't have to pay a thing.
All right, there you go. This world is changing, my friends.
Thank you, Doctor. Next question. This is from Mike Livingston. For Alan, what did your therapy in Germany cost? What is the precise name of the treatment?
Well, the treatment was about $10,000 a time. And theranostics is the treatment. That's the procedure. Does that help?
Yeah. Thank you. This is from Bob again. What would be the optimal PSA level to go for a PSMA PET scan to hope to see something while not waiting too long for cancer to grow?
To be honest, if you are after, I will say if you're more than 0.2, you have some chances of seeing something. But I will tell you this, I have seen patients with a PSA of 0.05 and still have metastasis. So PSA, well, is really good, and what is I mean, I love it, right? I mean, this is it's a screening test. Sometimes you need a baseline to see where you are at, so that we have something to do when something changes. And I understand this might be harsh, you know, but in terms of the toxicity, the financial toxicity that this might have. So the right question is that if you have a PSA 2 or more, you for sure are gonna 95% of the time you're gonna see something. But the question is, how do we start using this technology to prevent disease going, you know, jumping the fence and becoming a problem? So it's still gonna be an art of how to decide when to do it, and it's gonna be a based on high risk, you know, your Gleason score, your genetics. I mean, many things, but I believe this still need to be figured out. I mean, there are papers coming out right now putting cutoffs and things, but I still would like to say that it's an art, and you have to choose wisely, and you have to be mindful. But the bottom line is, as a baseline, I think is be very important.
Thanks, Bob. This is from Bob. What was the oh no, excuse me. This is from Fernando. Hi, I had an HDR focal monotherapy in UCLA in May of 2019. It took the index lesion out 4+4. I have a large 180 cc gland and have a small volume 3+4 and 4+3 on the untreated side. My PSA nadir was 2.5, now it's 3.9. What do you recommend going forward? I am a 78-year-old. I have PSMA PET MRI at University of California, San Francisco, prior to HDR, and it was all clear or no mets. I live in Florida, where is best place here to have a PSMA? Where is the best place here to have a PSMA PET? Question. And what is the difference between PSMA PET, MIR, PSA PET, CT?
Fernando, a lot of good words there. I think you summarized your journey pretty well. I can tell you that the MRI, PSMA PET MRI, that means that you're still doing the PET CT, the PET, the positron emission tomography, that is the imaging, the molecular imaging. And then with the MRI, you have some extra value that is because you're looking at soft tissues. But to be honest, it's not for everybody. I think a PET CT is the way to do it. It's faster and is more cost efficient. And I think you have to choose the right one. I would, in your case, if your PSMA PET was negative, or PSMA PET MRI was negative, we have to know, we will check when you did it, and if there any change in your PSA. When was your PSA at the moment of the of that PET MRI? And let's see what is your PSA today, and if the change is I mean, I think it was 2.5 before, and now it's 3.9. I think doing a PSMA PET will help to see where you're at. But I can tell you this: if you have a PSMA PET that is negative, and you're early in when I say early, you got to this before too many chemotherapies and all those things, it means that at diagnosis, PSMA expression, the amount of PSMA you have is predictive of the future, right? If you have a diagnosis low PSMA, you are more likely of dying with prostate cancer than without prostate cancer. And we could prevent some interventions that might not be in your best interest. The bottom line is, I believe that if there is a significant change in your PSA, PSMA PET will help us guide the next steps.
Thank you. This is from Rich. Who is the right patient for theranostics? Where can someone be treated using theranostics?
The right patient is a difficult word, but I mean, I believe we all could be the right patients at some point in our journey, if depending on many things. I mean, I believe that the PSMA PET will tell you if you're the right patient, right? If you have highly avid metastasis or highly avid disease, you can be you are a candidate. I mean, you have to. This is going to become more and more of an issue. Which is the right patient? Now that we're going to be having access to PSMA PET, right? People are going to get a PSMA PET done really early, right? And then what are you going to do with a patient that had one primary tumor, maybe one metastasis? What is the right treatment? Maybe you'll do proton like I did to my friend, right? To my patient, right? And you probably have. I mean, he had no side effects. He didn't lose a day of work. I mean, if you have a patient that comes with 100 metastases, like Alan, then you have to do something different. So I think the right patient means many things. So we have to take it at a case-by-case basis and personalize the therapy and the intervention for you.
Thank you, Doctor. The next question from Mike Livingston. Doctor, non-cancerous things light up in a PSMA. What happens to those organs during theranostic treatment? Do non-cancerous areas get hurt?
That's a very good question. So smart guy. The first time I saw a kidney, right, in a PSMA scan, I'm like, man, this is unbelievable. I mean, we're gonna fry those kidneys, right? It has a lot more. It basically had lighting up more than the metastasis. But we have seen, in my experience, I have not seen one patient that had severe, at least in our hands, and have to disclose this, right? There is a difference between many. You have a Honda, you have a Mercedes or something. There's a difference. So in the hands of the people that have studied this and have take the right precautions, I mean, I believe you have low chances for side effects. And Alan is an example. I see many people like Alan. Like I can tell you personally, I have not seen somebody that had gone into renal failure because of this. The kidneys are there to flush the radioactivity. Whatever is not being used, whatever is not going, to the cancer, you just throw it away, right? The salivary glands are doing the same thing. Low doses. The important thing is the right dose for the right patient. You don't want to give the same dose to Alan that is 6 feet plus than to give it to somebody that is 5 feet, right? And small. So it has to be personalized. And that's something that I hope that in the future we can get better at, because in Germany and other places are doing this. Of course, they are 15 years ahead of us, 10, 15 years ahead of us. So we need to make sure that we don't reinvent the wheel. We take the good things from other places and implement it here. But I believe that you shouldn't be giving the same dose to a 300-pound guy and a 100-pound guy, So there has to be a personalized element here, and that's why we are going to decrease the side effects.
Thank you. Dr. Is Loma Linda actively treating people using thermognostics?
So the answer is yes and no. We have a clinic in partnership with Banff Health and industry sponsor, and we're having the patients evaluated. And at this point, since it's not available in the States, we take those patients to Germany, and some people in this call are going to Germany, have gone to Germany. But we hope that at the end of this year, beginning of 2022, we're going to have this in-house, and we are prepared to help a lot of patients. And very few people had the blessing of having the depth and the experience with these patients in theranostic periods, right? I mean, this weekend I'm going to Germany. I'm going to be involved in the care of 40 men, So I've been doing this for a long time, and I can tell you, in the experts' hands, this therapy is very valuable. I mean, even when it's done, but I mean, I can tell you that we're gonna have to change the way we do this. We do these theranostics interventions here. We have to regulate it, and they have to be regulated. They have to be an academy that looks and trains physicians, because we need a lot of physicians to join here and help us, because there are 3 million men that could benefit from this. I mean, at least imaging, right? So there is a tsunami coming to this field in prostate cancer, because many men, once they know that this is available, they would like to be part, and rightfully so, they would like to be part of this. So we better open the doors, and I don't want to see a future where what's good for you, but you cannot join because you're not, you don't have a spot. So we need to build the infrastructure. You need to work together to make this happen.
So, doctor, when you send a patient to Germany for this therapy, are you involved in that process, or do you just turn it over?
100%. 100%. It's my responsibility. I create the treatment plan. I follow the patient. If you can see Alan, in between the therapists, we're working together. So it is my business.
Yeah.
These patients are my friends. So whatever happens to them, I know, and I know before anybody else, basically. So
the last question I have is, when the institution that you send them to in Germany, how extensively are they involved in this therapy? Are they a leader in this type of therapy?
So Bob Burka, under the leadership of Dr. Baum, Dr. Kulkarni, they have been doing this. Actually, Dr. Baum in Bob Burka did the first PSMA therapy, and it was in 2011. So they've been doing thousands of cycles of therapy with great results. Even when the patients they saw over there were patients that had a lot of disease and had many interventions that were actually making them weak. And as you know, if we want to get good results, we need our immune system to join forces and so we can work together and destroying the cancer. I mean, a patient of mine came 2 weeks ago, right? Actually, 2 patients came 2 weeks ago from Germany. These patients were with fentanyl patches, all these medications. And they called me and said, look, for the first time in how many years, I have not taken a pain medication in like a week. That's just crazy. I took my patch off. I mean, I see this, all the time. And you know what? It's just great. And I'm telling you, I make 0 cents of the Germany stuff. The only thing I make is a satisfaction to see these patients. One of them told me, hey, I play golf again. I'm a little tired, but I play golf. I'm like, well, you haven't played golf in a long time. It's okay to be tired. But remember, after the therapy, your immune system is hauling truckloads of dead cells and throwing away, making it pieces, throwing it away. So you have a reason to be being tired, right? So look, I'm not saying that this is the last Coke in the desert. I'm just saying that the way that this technology is evolving, it is going to help to create precise interventions, and precision is better. Precision will help us cure prostate cancer, and precision and timing, right? So the earlier you take care of the problem, the better the outcome. So like there's studies showing, right? If you had chemotherapy before this, your chances of having a big response drop a little. If you so the bottom line is the targeted interventions done early equals better outcomes. And that's just true in prostate cancer, and it's true everywhere else in life.
Thank you, doctor. Thank you very much. Excellent presentation. Dave, I think we've wound this one up. Okay.
All right. I will be glad to answer any other questions.
Larry, did you see the last question that came in?
I guess I didn't. Okay, it says, this is from Michael. For someone who had a Gleason 4+3 and proton therapy and is monitoring PSA, how high would you allow PSA to go before you start PSMA PET scan?
That's a very important question, and I can tell you, if you are one of those 30% of patients that the disease is going to come back because basically we didn't have the right diagnostic imaging before the radiation, I think you want to watch out. I think proton will have given you time and have bought you time for you to be in this era where you can do precise next generation imaging and then go from there. I will say, look, if your PSA is above 2, you should get a PSMA scan. Like I said, I'm not talking to you guys as I'm going to be talking to academics and to other doctors, and I would show evidence, I would show papers. To you, I'm telling you that if you have proton therapy and you have gotten 10 years of disease-free or a long time, and your PSA start growing, you don't want to throw that to waste. You want to make sure that if there is something there, you see it, and you see it early, so you can actually do something about it while it's localized. Where you don't have metastasis everywhere. I don't want to tell you that theranostic is for everybody. I'm going to tell you that in the future it might not be any theranostics, right? Because the surgeons are going to take the cancers early, and the radiation oncologists are going to hit the disease a lot earlier, and maybe we'll do theranostic for people really, I mean, early in the disease before any of those interventions. And eventually this will be a cure for prostate cancer, and I'll be the happiest guy. We'll get this group together and we'll do a party, right? No more prostate cancer. But until then, I think we need to watch ourselves, our backs, and try to make sure that the disease does not surprise us, so we can get the disease early, and we can, we can get the right therapy at the right time, and of course for the right patient.
Sorry, one more question came in from Bob.
Thank you, Dave. How about PSA of 0.2 post-surgery after 7 years? Do you do PSMA PET scans for that kind of situation?
I mean, it has not been changing for 7 years. Man, kudos to you. I mean, you probably were one of the patients that didn't have the disease outside the prostate, and that's why I think patients like you are the pride for surgeons. You know, they have done a great job to do this. So patients like you, I say, if you see the PSA doubling, I mean, in less than 6 months, I will think something to do extra. And I'm telling you, PSMA imaging is going to be available. It's going to be more and more available and more affordable. So just make sure that you don't get surprised. If your PSA is that low for so many years and it's not changing, I'm very happy for you. I'm very happy. So like I said about the surgeons, the best surgeons are the ones to know when not to operate. I think that the best theranostic doctors and the best radiation oncologists and the best oncologists are those to know when not to do anything, just evaluate and wait. So it is an art. But for you, I think somebody with PSA 0.2 for 7 years, not changing, I would be very happy.
I have a question.
Go ahead.
Yes, I'd like to ask Alan, when you had the procedure done, one of the things that I've been told in reading is that with this type of nuclide or whatever you call it, that there's salivary, in some instances, salivary drying up and also eye fluids, and your eye, did you experience anything? And was it, if you did it improve after time?
I didn't experience either one of those. I didn't experience that. So Frankie might be able to give more information on it, but yeah. I didn't experience either one of those. And I don't know if hydration has anything to do with that, or just before you go in and during and after. But I had no problems.
Great.
Yeah.
So in the past, this has been a problem. I think now we know that with lower doses and less and patients that had less chemotherapy and less therapies before this, less non-theranostic therapies, it correlates with how good the salivary glands do. So it has to be how healthy you are when you get to this therapy. But we have, I mean, this is, we have seen problems with salivary glands when you do high dose actinium. That is high. I mean, that is well known. And patient will say, well, I'm glad that I'm here, even if I don't have salivary glands. But I think the goal would be to keep the physiology as normal as possible by modulating what dose you get and when you do it, and not only just do 5 therapies every this many weeks or 6 therapies. No, you evaluate and you stop and reevaluate before each therapy. So there's a big future for this. We're gonna be changing how we do things, but I hope that we could learn from the past mistakes and from the successes of the past, so we don't have to reinvent the wheel.
Okay, one more question here. This is from Michael. I'm sorry if this was covered, but Alan, what was your situation before you decided to use theranostics, Gleason score, symptoms, PSA, etc.?
My Gleason score was 7 to 8. I had 7s and 8s, and my PSA was 52. But my X-ray was shown tonight, and I had it all over. So, like Frankie said, I had 100 lesions, but my PSA was 52. Does that answer that?
Yeah, let me add a follow-up question. Have you had a PSA since your therapy? And if you had a PSMA, how many do you still have any known sites of cancer?
I think I have 3 small spots that have been in recession, dormant. I'm going for another PET scan end of the month. Frankie, we have one set up so we can take a real good look and see what's going on.
So your PSA, what is your PSA for the last year?
0.01 since I come back from Germany.
That's how long ago?
The 20 of February of 2020.
So it's a year and a half, almost 2 years, coming on 2 years.
I'm 0.01, and I do a variety of things.
Yeah.
I believe in homeopathic things too. So I've run into gentlemen that have been drinking cancer herbal teas 25 years ago that I didn't think much of it then. And there's a lot of things that can be shared amongst cancer people that we can put in our bodies too, that I think might help our cells and our blood and our, just a whole ream of information. So I think a lot of what we put in our mouths help our bodies to stay healthy while we're surviving after our treatments too. So
I believe I'm with Alan here. You want to be a holistic patient. You want to eat right. You want to exercise. You want to be healthy, and it's all part of the same thing. And I mean the other questions, I mean, maybe we can answer later, but we're doing we have access to PSMA imaging, and we are going to we will be able to design a plan for you if as a specific patient. We'll treat you as a patient, not as a statistic. We treat you in a personalized way, and that's the way that prostate cancer patient needs to be treated. And you know, it's going to be an effort that is going to cross paths with all specialties, and hopefully all together we can design a better world, a better future for prostate cancer.
So let me ask this question, Doctor. What radioactive tracer is being used or considered to be being used at Loma Linda, okay, with the PSMA?
So lutetium-177 is going to be the radio tracer that we're going to start with. I also believe in tandem therapies and alternative tracers. For some patients, it will going to come to us so late that lutetium is a lower radiation. This is a beta radiation. So when you go to alpha radiation, it's like punching 1,000 times harder. So I believe that we are working in the trials here, and I'm blessed to be part of these trials that are going to be starting in the US soon, because we need to keep moving the field forward. As of today, what is going to be FDA approved in the future is going to be lutetium-177, and you know, and we're going to start there. But there's always going to be a room to make changes and to do better, especially with patients that have been heavily pre-treated, and have disease that is resistant to many things. I think that is the reality of this. We need to do more. We need to make sure that we don't sit down now that we have something better for many patients. There'll be some patients that are going to require something else.
Okay, next question. If PSA was undetected, this is from Bob. If PSA was undetectable after surgery for 3 years and then started to rise now at 0.2 over 4 additional years, should I do a PSMA PET now or do I hold off a little longer?
It's a good question. I think I would like to look at all the pictures, and I mean at all the data available for him, for you, Bob, and we can make a decision. But if you're above 0.2, you're still if you're normal, right? If you're part of the 90% of patients that the PSA correlates really well with your disease, you should be fine. Imaging is important because imaging, at least PSMA imaging, can help not only to plan therapy but also to plan when not to do therapy, and it will give you some baseline of where you are at. So there is no right answer here. I probably need to sit down and review more of your records and see how the risk and all those things. But the next question is, which is better, gallium or F18 PSMA? To be honest, gallium got us here. Now F18 is going to be available everywhere because with gallium you can do, a couple people a day per location. With F18 we can do hundreds, right? So the future is going to require high throughput, and F18 is one of that. Yes, there are some sites in the F18 that are there's a little false positive because it's a little bit more sensitive. We just need to make sure that we learn how do we read these scans. So I'm not worried about that. I think having available PSMA is a great thing for prostate cancer.
I guess we got one more here. Where do you think PSMA theranostics is in Australia as compared to Germany?
Australia started after Germany, and I believe that is in a case-by-case basis. But overall, the Australians have been doing a great job at prospective trials. They have been advancing a lot. But if you are in the hands of the experts, I believe that I will go with those that have done it the much longer and that they're doing it. So I guess the bottom line is I believe that there are amazing people in the both sides of the world. In Germany and in Europe and in Australia. We just need to find the right protocol for you.
Yeah, so here we got, so this is from Bruce. For the diagnostic radio tracer, rather than LU-177 therapeutic treatment, please, what are you using at Loma Linda? I think you answered that, but go ahead.
So I think, to be honest, now the F18 is gonna be we have more access to with F18. We don't have the capacity to do gallium at this point, and F18 is gonna be more available everywhere. So as of right now, I can probably get you a scan in a week or two after putting the order. So it's that available, and I have multiple partners that are in different institutions. I'm not gonna wait to do a PSMA scan when I have availability at my center. We get a PSMA scan where it's more convenient for you, when it's faster, and when it's more efficient. So my goal is to get you to the door, to get the right plan for you, not just to send you to a place that my commitment is to patients. The institutions are great helping me get this to the next level, but this is all about what is easier for patients. I have a patient that got an image in Orange County and another one that got an image here in San Bernardino. It can be done, and it needs to work better for you. So I'll be glad to send you anywhere that is that they do the right imaging modality, and that I have access to review the pictures.
So I think that's it, Doctor. I think we've had more questions tonight than from any speaker that I could recall in recent history. This has been a very interesting subject. You've done a great job, and I want to thank Chuck, okay, for participating in this presentation. Thank you, Chuck. Is there a way that you can clap for these people, Dave? I want to clap.
Hey, it's an honor. Thank you, guys.
Thank you.
And I'm
Thank you.
happy to see all these cool people
Yeah.
around.
I'll be talking with you, Doctor.
All the best. Bye.